Hello, everyone. I'd like to talk a little bit today about the information found in Chapter 23. As I was reviewing this, I did find some information that would actually be found in Chapter 22. It's not that much of it, though, and it shouldn't be a problem for you just to turn back and look at that information in the previous chapter. So I love this particular picture. I'm hoping that everybody can see the beauty in flight and know that when we care for babies that they can do great things later on. Let's talk a little bit about an APGAR score. An APGAR score is a diagnostic tool that's used to assess newborn cardiorespiratory adaptation to extrauterine life. This tool is a rapid assessment to help us decide, do we need to intervene? The issues that we're looking here, you'll find on the left-hand side, they are heart rate, respiratory rate, muscle tone, reflex irritability, and color. This APGAR score is done at 1 in 5 minutes. It is done at 10 minutes if we have fetal distress noted in the 1 in 5 minute and if it continues. Scoring is interpreted and the nursing action is as follows. A score of 7 to 10, which interprets to minimal difficulty adapting to the outside world, and we're just going to monitor the baby. A score of 4 to 6 means that we need to pay special attention to this newborn and perhaps intervene with a little gentle stimulation and some rubbing, maybe possibly even some blow-by oxygen. A score of 0 to 3 indicates a serious respiratory depression, and we really need to intervene at that point in time. 10s are rare. In practice, I have seen them, but not that frequently due to acrocyanosis. And we all know what acrocyanosis is at this point in time, having talked about it multiple times in the previous chapter. Okay, this next slide I want to talk about lays out what our immediate interventions are in the delivery room after the baby is born. Of course, by far and away, the most important thing is to make sure that we are assisting to establish breathing, which is the most important. Again, keep in mind, considering maternal narcotics, do we have a sluggish baby? Do we need to give some Narcan? And importantly also to make sure that we have that blue bulb or even some wall suction dew handy in case there's some music there, some mucus there. Remember to listen to our lung sounds. Again, it's completely possible that we're going to hear a few crackles at the bases. We may even see some nasal flaring in those first couple of minutes. Again, it's all about making sure that those things are clearing up or have cleared up. Next thing that we're going to do is make sure that we're stimulating the baby to cry. Remember years ago when you used to see in the old movie shows where they pick up the baby by the feet and slap their butt? Well, we no longer do that these days, but we definitely want to try and get that baby to cry, to remove that residual fluid that's left in the lungs. And again, next to that is we gotta provide warmth. We're gonna dry that baby off and get the wet linen out and stimulate the crying all at the same time. These are most important things to do. The list is important. Those three are like the things that you're going to be doing in the first 10 to 20 seconds of life. Remember to take a look at the cardiac video and make sure that you're aware again of the murmurs and the shunts that a failure to close that cause those murmurs to occur. Physical assessment, I could spend literally the whole day going over that physical assessment, but I think that the textbook again does a really great job of that, so I'm going to refer you back to that. Knowing that the newborn undergoes many biological changes in the first 24 hours, that's the most critical period of time when we need to be watching that baby. There is an initial exam that is done in the recovery room to assess kind of the temporary well-being and can we get this baby out to the mom and can this baby go ahead and breastfeed. But in most institutions, an in-depth exam is required to be done by the first 24 hours of age. And in any case, we're always going to make sure that we're keeping the baby warm, complete the vital signs, a general appearance, and tone. Very, very important tone. We want to make sure that we've got a flexed baby that has good color and respirations and heart rate. Length and weight is also done, and then the Ballard. Vital signs. When we talk about the vital signs on a baby, we're going to include pain. Pain is very important because, as Jaco calls it, it is the fifth vital sign. Temperature should be taken axillary. An apical pulse should be counted. It should be 120 to 160. If the baby's crying, it can be up to 180. If the baby's sleeping, which typically doesn't happen right at birth, you can see a low rate of 80 to 90, but certainly those two, the bradycardia and the tachycardia needs to be watched. Again, it can be irregular, so it must be counted for a full minute. Respirations are normally around 40. You can have a little less, you can have a little more. Again, crying is going to be more. Apneic periods of 20 seconds or less is acceptable, as talked about before. However, it should resolve in the first day or so. Problems include persistent tachycardia or bradycardia, and remember both the heart rate and the respirations can be shallow and irregular. Blood pressures are not routinely done in most institutions. However, that does not mean that they would not be done where you're going to be working at. We're looking at numbers around 75 over 42 plus or minus about 14. Newborn pain requires a special assessment scale since newborns are not verbal and cannot describe their pain. As healthcare providers, a couple of tools that we like to use is FLAC and NIPS. But it's important to differentiate painful stimulus causing versus newborn communication. Remember, babies cry to communicate. So you have to look at the whole picture. Is there a reason for this baby to be crying? Or is the baby just saying, I'm really tired of this and I'd like to be wrapped up and held and rocked and swaddled? Another nice picture I'd like to include. Other care that occurs in the delivery room, a couple of things, some medication. In the baby's eyes, we instill erythromycin to prevent undiagnosed maternal transmission to neonate of chlamydia and gonorrhea. It is to prevent ophthalmia neonatorum. You can postpone the eye treatment for bonding. The problem is you don't want to accidentally forget to do it. Then when we look at the newborn IM, it needs to be administered in the vastus lateralis muscle with a 25 gauge 5/8 for IM. The first hepatitis B and the vitamin K are the two IM injections the newborn will receive. Vitamin K is given to prevent hemorrhagic disease of the newborn. It is given IM to help the liver produce clotting factors, kind of a jump start. If you have a mom that is hepatitis B surface antigen positive, then at that time of birth, the baby, after a bath, is going to be given 2 injections. One would be the first of the Hep B vaccine trio, and the other is going to be the HBIG. Okay, let's talk about issues of size. Clearly, when the baby is born, the nurse is going to take the length and the weight on the baby, but I want to talk a little bit about some other classifications that are kind of important to know. Newborn size is classified as, first option is SGA, which is small for gestational age, which is less than 2,500 grams at term. These babies have problems or difficulty with regulating their glucose, their protein, and their bilirubin. Another size is called an AGA, which is an appropriate for gestational age, and that would be our goal for our baby's size at birth. The last one is called LGA and or macrosomia. These are large for gestational age babies, and most of them are over 4,000 grams. They come with another whole set of issues with regard to bleeding postpartum for mom. Also, they have a difficult time maintaining their glucose level. They use more of it, so then they're more apt to bottom that glucose out. They also have a fair amount of birth injuries because they are so large. So they have their own set of issues. IUGR. IUGR stands for intrauterine growth retardation or reduction. Um, these babies are born small simply because for whatever the reason, they have a lack of adequate nutrition and oxygenation during their intrauterine stay. They can be born to, so high risk mothers are adolescent mothers, those that have placental anomalies, those that have a systemic disease like high blood pressure, those that smoke a lot, and those or moms that have an intrauterine infection. Talk about issues of age. Here we have what your textbook is defining as early preterm or premature, late preterm, term, and post-term. Early preterm is those babies are the preterm ones that are born before 37 weeks. Um, they have a risk for long-term and short-term problems depending on how premature they are. They have a higher incidence of breastfeeding problems, and they're susceptible to TTN, which we know is transient tachypnea of the newborn, and RDS, which we know is respiratory distress syndrome. Late preterm births in the U.S., we're looking at 71% of all preterm are the late preterms, which are the ones that are born from 34 weeks to clear up to 37. And 8% of all births are late preterm births. This is a huge group of babies that are being born, and we're seeing this increase. It's associated with elective inductions and sections that are scheduled before 39 weeks. Well, why is this such a problem? Well, in the past, these babies that are born just a few days early have been considered normal and placed on the regular newborn unit with the mom at the bedside. It was found that even though these newborns initially did well, they soon were exhausted after using all of their reserves and transferred to NICU under less than optimal circumstances. So these great imposters need to have more supervision, and that's why we now have that brand new group of babies. Remember we talked about those gentle giants in the past? I want to bring it up again. So you have this really large baby, 8-9 pounder, which should be normal, but it's born at 34 weeks. And after about 12 hours or so, this baby is unable to nurse. The feeding drops, sugar drops, and temperature drops. You can see how these particular babies can have more issues than just our normal term babies. This is a tool, it's called a Dubowitz or a Ballard to assess gestational age. It is based on a physical and a neuromuscular assessment. Again, it is a tool that helps us to specific our care for each baby based on their age and their needs. Jaundice. I think we have talked about jaundice a great deal in the last chapter, but let me touch on it again, okay? Try to recall the causes of hyperbilirubinemia is directly related to the breakdown of newborn red blood cells. If the neonatal liver cannot conjugate all of that bilirubin for excretion, the serum level will climb. If this level gets too high without intervention, the baby will develop what is called kernicterus, which is an irreversible brain damage. What are some of the reasons we see high bili levels? If you think about it, simply any reason for an increased level of RBC breakdown. So high risk groups include any baby that has an ABO incompatibility, any baby with birth bruising, like Caput, any baby that has polycythemia or cold stress or prematurity or dehydration. There's two types that I need you to learn about. The first type is called physiological, and that is bilirubin or jaundice that appears after 24 hours of age. It usually peaks at about 3 to 5 days, then it plateaus out. Most of the time, this is considered benign. That doesn't mean that we're not going to watch it. That just means that we need to monitor that, but possibly some lights if we need to, but more often it's just increase the feeding, because the more feeding that you put into the baby, the more that they're going to stool, and the bili is excreted through stool, bile, and urine. The second type is a little more pathological because it's called pathological. It is unconjugated bilirubin that is not ready for excretion, and it is considered pathological in nature. If it gets too high, we really need to look at further attention. The other thing is it appears within the first 24 hours. It is usually associated with Rh incompatibility between fetus and mother. Notice the difference between an ABO incompatibility and an Rh incompatibility. When we talk about conjugated and unconjugated, let me just spend a minute on that. Conjugated bilirubin is ready for excretion. It is also called direct bilirubin. Unconjugated bilirubin is free-flowing. It is not ready for excretion, and it is also called indirect bilirubin. It is the one that turns the skin yellow. This is a graph that shows you the trend, because what we want to do to diagnose jaundice and kernicterus and whether or not we're going to take further steps to treat the jaundice has to do with the time period. As the time passes and the baby gets older, higher levels become more acceptable. Signs and symptoms to assess. One in particular that's easy enough to do is if you see the nurse taking her finger and blanching or pressing down over a bony prominence, she's looking for yellowing. Babies with higher jaundice tend to be sleepy. We're also looking at cephalocaudal progression. Bilirubin or jaundice usually starts at the head and works its way down. So if you're looking at the baby's eyes and they're turning yellow, then the next day the chin is more yellow, you can believe that jaundice is climbing. And it should be, most institutions will routinely take a bilirubin level prior to discharge. Here we see phototherapy to reduce the unconjugated bilirubin. A couple things to make sure, important to provide the newborn that's getting phototherapy a mask to cover their eyes. You want to make sure that as much of the body surface as possible is being exposed, which may indicate just a diaper alone. You want to make sure that we're providing warmth and a way to monitor the baby's temperature. Also important to make sure that they get their feedings. Two types are available, and I think you see one. It's called an overhead bank. It's on your right hand side, and the blanket on the left hand side. The only times that babies should be taken out of Billy Lights are under two conditions. Once for feeding and bonding, and the other times for lab draws. When we're talking about a heel stick, I just wanted to give you a picture of showing the proper placement for this heel stick. It's usually done on either on the lateral side, either right or left. A little bit about protective environment. You're going to see things like uh, a big to do these days is abduction. So what we see now are these little, I call them baby low jacks, that are actually put on the baby at birth, and it is connected to a computer so that if the baby gets too close to the door, this goes off um, and alerts staff. Specimen collection is the heel stick, which I just showed you. When we're talking about pain from a circumcision, how Sweet Ease works is not really understood very well, but we know that it does help ease some of the pain, and babies are often given Sweet Ease. And here shows a neonatal safety device. This particular one has one on the mom as well. The ones that I have seen are only on babies, but pretty much every institution that I have seen is now instituting these. It's important to assess and chart the 3-digit number. It's a safety issue, and it's asked for that charting, or I'm sorry, for that to be charted in the medical record as part of the baby's record. Circumcision. Let's talk a little bit about that. Circumcision is completely up to the parents to choose to do or not to do. The American Academy of Pediatrics has come out in the past, but tries to maintain a neutral stance on it. It is a surgical removal of part of the foreskin. It is most often done by an obstetrician because it is a surgical procedure. However, I have seen some pediatricians that do it as well. There are actually two types that I have seen in my practice. The one that I see most often uses the Gomco, and you'll see what that is in the next slide. But I have also seen them use the bell. The most important thing that I think we need to talk about is neonatal comfort. What I have seen of late is the use of EMLA cream. It is a topical anesthetic that is put at the base of the penis prior to surgery, and it's left in place about 30 minutes. The thought is to numb the skin prior to the dorsal block. And then the dorsal block is also an injection of lidocaine that's given at the base of the penis. And as I mentioned before, for pain, we give Sweet Ease, and there are some pediatricians that will actually order Tylenol. Care involves checking for bleeding, monitoring for the first void after surgery. Most important, if we have a baby for whatever the reason has more trauma, and the edema is occluding that urethra, we as healthcare providers need to be aware for that. We need to monitor also for infection and follow whatever the hospital protocol is. Most institutions I've seen applies a Vaseline gauze at least one time after the surgery. In your care, if you see a blood clot or yellow exudate, you should not remove that. Contraindications for for a circ is an epispadias or a hypospadias. I think it's a good time here just to talk about those that choose to non-circumcise. Be sure that parents are taught not to retract the foreskin, since it should not be pulled back until about 3 to 4 weeks old. This is a picture of a, well, they call it a Yellen clamp, which is also known as a Gomco. And this is the one that you're going to see in our two institutions. I've seen both at Hurley and also at Genesis. Newborn behavior. Now this is the information that I really wanted you to take a look at. It is on page 577 and 580, which is part of chapter 22, but I did not want you to miss it, and I didn't get it in there. So important to have an idea about newborn activity levels and the 6 states, and how they're impacted by gestational age. We can figure that out. If they're premature, of course, you're not going to see the same level that you're going to see on a term baby. Sensory sight at birth, babies can see about 12 inches, and it's interesting to note that that's really just about how far it is for the mom to be cuddling the baby and looking at baby in a way that's called in face. So mom is looking at baby, baby staring back at mom in the Madonna hold. Hearing should be tested before they go home. Taste, studies have shown that newborns can distinguish taste, hence the favorable reaction to sweeties. When we look at the response to stimulants, it is clear that newborns respond to soft touch and voice, and clearly we can document pain through the FLAC scale. Okay, newborn bath and cord care. It's important when we're doing a bath to provide a safe and warm place. We want the baby to be washed from cleanest to dirtiest, just like we do in the adult. It doesn't necessarily have to be done every day, a full bath. The dirtiest parts around the neck, what little neck they have, and of course their bottom. Take advantage of this time to teach mom and dad about the body parts and the normal reflexes. They love to look at their babies, and in some cases it's even okay to allow the parents to do it in your presence. Cord care has been kind of bandied about in the last 10 to 15 years. I think that most institutions at this point in time are choosing just to monitor and no treatment unless necessary. Average normally falls off between 10 and 14 days. You don't want to submerge the baby in water until the cord drops off. The whole point is to dry, dry, dry. So we want to expose it to air. We want to follow the individual doctor's recommendation. Now those can change from doctor to doctor. Be sure to diaper below the cord, and be sure to assess the bleeding and the oozing or foul odor. Discharge teaching. This has really changed through the years. Again, I'm going to defer you to chapter 23 for specifics on these. I have covered quite a few of them already. Important to know what these topics are, at least the basics. Sudden infant death syndrome, or SIDS. It is defined as an unexplained death of an apparently healthy infant under 1 year old. Postmortems don't reveal any apparent cause. These babies are usually well nourished. There's lots of theories that exist out there. One of the most recent points to a neurological brainstem dysfunction, possibly prematurity. We've seen it genetically linked in families. We've seen these babies often pass away from moms that do a significant amount of smoking. We've seen some co-sleeping involved in that, and generally speaking, it does occur while babies are sleeping. So in our discharge teaching, we want to make sure a couple of things: that the mother watches the Back to Sleep movie. That's the intervention that was instituted back in the 80s. Since then, which has been a significant amount of years, close to 30, if not 30, we have seen a decrease in SIDS by 30%. The other thing that we're doing now is family screening of babies that have had SIDS in the past. Subsequent children born to parents who lost a child to SIDS is observed closely. Autopsy can help with grieving because somehow parents are feeling that they've done something wrong, along with support from the healthcare explaining that this was not the parent's fault. Safety. We're talking about back to sleep and SIDS. We just talked about that. Car seats are now mandatory. One of the things that I wanted to talk a little bit about is called shaken baby syndrome. Again, I believe that this is a mandatory movie that parents are required to watch before they're discharged from the hospital. In my personal experience, in my personal practice as a healthcare provider, in the last 5 years, I don't know what the statistics are, but I know that I am seeing more abuse come in through our hospitals from shaken baby syndrome. The number one reason, when asked, the perpetrator will say, "I just needed the baby to stop crying." And that does happen. When you shake the baby, they do stop crying. So there is some success to it. It also leaves us with babies that are severely handicapped for life. If you have me for your clinical educator, I have a story that I can tell you about that. It's a little long for our tape here, so I'm going to choose not to do that. Again, I hope that some of the information that I've given you today is helpful and appreciated. Thank you. Bye.